Still having some difficulties. Okay, thank you. I hope to review and discuss some routine testing used in the last 35 years. Try to cover that quickly. The new testing put in place in the last 15 years. Then comparison, talk about the advantages and disadvantages. And then general considerations and interpretations of results, and especially rethinking some of the new results that we have with the real-time PCR. Quite obviously, histopathology is the mainstay, and I'm a histopathologist, so I had to make that statement because I know there's several other histopathologists here. But obviously, necropsy and histopathology is always a good place to start, put you in the right direction. And as always, we need timely collection. We need fresh tissues for any time we're talking about diagnostics. I had a case here a number of years ago, about 20 years ago, a veterinarian west of town. I brought in some samples, and they were having an increased numbers of deaths in a particular pen at this feed yard, and they were so rotten that we couldn't do anything with them, or we did our best, told them we really need some fresh tissue. So he says, well, I'll tell them to call me next time they have a dead in this pen. So sure enough, about a week later, he shows up the door shortly after 8 o'clock with a big smile on his face. And I said, oh, okay. He said, yes, I told them to call me. So they called me early. In fact, so early that I decided to run out there and collect it before I went to the office. And when I got out there, he said that they didn't even have the dead out of the pen, so he latched onto it with his pickup, pulled it over the dead pile, collected the samples, boxed them up, back of his truck, and heads off to the lab. And so on the way to the lab, people keep going by and honking and pointing in the back of his pickup, and he thinks, well, are my specimens spilling out? And he looks around, no. And after about the third or fourth person that honked and pointed back there, he remembered he forgot to unhook that calf that he pulled out of the lot. So I assured him we really don't need them that fresh. But anyhow, many stories. But fixation is important. If it's at all possible, those tissues need to be fixed on the spot. If not, as soon as they get back to the clinic. We know that we use a 10% solution of formaldehyde, but it's also 1 to 10 ratio of tissues to fixity. If you don't do that, the tissues will fix on the surface the first 2 or 3 millimeters, maybe, and then what we get is tissues that are fixed on the surface, and everything else is just like you'd set it on the counter for 3 or 4 days. The more dense tissues need to be trimmed more thinly than the alveolar tissues like the lungs. In fact, we received containers where it's 50, 60, 70% of it is tissues. They're large hunks that are not fixed. What we'd really rather have are smaller pieces of tissue that are trimmed this way. And on the lung, we'd like to have multiple sections, maybe what appears to be normal, and 2 or 3 sections of the abnormal at different levels. So selection of samples, fixation is very important. And again, we have neurological cases where we don't get brain, or digestive cases where we don't get intestine. So that's always something we like to remind our clients about. Weakness, undesirable outcomes. We don't find any lesions, and of course, that may be related to. Excuse me. How do I turn it off? Excuse me. That may be related to the advanced autolytic state, et cetera, et cetera. Target tissue is not submitted, but we do the best we can. We can make and confirm this. We're talking about the strengths and advantages. We can confirm. We have what we call pathognomonic lesions, IBR, the pseudomembranous diphtheretic lesions, necrosis, etc., with herpetic inclusions. We can tell you it's IBR. Atypical interstitial pneumonia. If you move out of the, frankly, blatantly pneumonic areas that have Mannheimia, Pasteurella, etc., go back into the dorsal lobes of the lungs, we can tell you for sure, yes, it's atypical interstitial pneumonia. You don't need to do any further testing. Mannheimia hemolytica, even though we don't necessarily isolate that organism, those leukotoxins, which are predominantly present in your Mannheimia hemolyticas, the oat cell formation, again, we can tell you, regardless of what we do or don't isolate, there's been a Mannheimia involved in this. Age of the lesion, I mentioned a while ago, multiple sections of the lung. If you go down to the bottom, you're probably going to determine how long, we can determine how long that infection has been there. If you go up to the top, we can tell you that, yeah, this is the acute area of the lung, and we really can't tell you, yes, that cap arrived with a pneumonia. So we have to have the chronic area and the acute area, especially for culture purpose. The acute area just below the line of demarcation between normal and abnormal is what we really need for culture. We can use histopathology to categorize the type of process that's going on, whether it's infectious, non-infectious. Have to remember that many of our toxic compounds don't necessarily produce lesions, and we often have non-specific terminal or agonal lesions, and especially after they get a little PMA on them, it's very difficult to determine what is hemorrhage and what is just imbibition of hemoglobin, the breakdown of hemoglobin spreading to all the tissues, making everything look red. So that's another reason we like to see you post them early and get them into fixative. But the non-specific changes to petechial, myocardial petechiation, epicardial, endocardial, some froth and fluid in the trachea and in the lungs, that can be a terminal, non-specific change that we see in many instances. If you really have heart problems, you're going to find a bad heart, or you're going to have a fluid in the chest cavity, or you're going to have fluid in the abdominal cavity. The absence of lesions, if we have good tissues, and we can say we don't find any lesions in these tissues, then we can say we can rule out a number of things, at least relative to those tissues. Results possible in 2 to 3 days. In many instances, we always have to fix them 1 and sometimes 2 days if brain is involved. But usually the 2nd or 3rd day, we should be looking at those slides. And if you're in a hurry, always let your diagnostic lab know. Please call me as soon as those come off. Put them on the top of your stack, and we'll work from there. New technology, and I know those of you say, new technology. Last 10, 15 years, that's not new technology. Well, I've been at the lab for 39 years now, and so the last 10 years, that's pretty new technology to me. But one of the booms is immunohistochemistry. And basically, we've adapted the ELISA technology, and we're using a slide, a paraffin section. We apply the antibody, the secondary antibody, conjugated with an enzyme. And then when we apply the binding, the chromogen, it binds with the secondary antibody and produces a nice color. So we can put a cover slip on that and take a look at it. And this has really moved things forward. There was a pathologist, I believe, at the Guelph lab. And back a number of years ago, before we had the technology and the techniques that we have now, the pathologists were always fussing at the microbiologists because they really couldn't find what we knew was there. And so this particular pathologist, once immunohistochemistry came on board, he almost eliminated the microbiologist. He could look at everything and determine by lesion and or the presence or absence of those organisms using immunohistochemistry. So he just didn't even need the microbiologist. So I was amused by him. We get a tremendous amplification of the signal, i.e. the infectious agent. And at one time, the only way we could reasonably call a pathology lesion is to have a pathognomonic lesion or inclusions for viruses. And now then, it's very easy. These viruses are present in relatively large numbers. We can never even imagine them before with a light microscope. But now then, we get that tremendous amplification. Also, a cross-section of the esophagus. We've known for years that those lesions in the esophagus, we assumed that they were related. Those erosive, linear erosive lesions were associated with BVD. Now that we can look, yes, there are BVD viruses associated with that lesion. So it's very sensitive, very specific. Utilizes a sectioned paraffin section, and we actually store these paraffin blocks. So in many instances, if you call a week or 2 weeks or 3 weeks later and you want immunohistochemistry, we still have the paraffin block. We've gone back years now and looked at cases because we maintain those paraffin blocks 15, 20 years. Depends on storage capacity. But it doesn't require a live microbial agent, unlikely interference from vaccine antigen, and it has unlimited possibilities with all infectious agents included. Again, this is one thing that I'll emphasize. You have to put the clinician's head together, the pathologist / diagnostician. Pathologists, by and large, have to become diagnosticians. And we put all that information together along with the history. Hopefully you can come up with an answer that will be of value. I might also mention one of the privileges I've had in my learning experiences with what really goes on in the field and how to best help clients has come from the ability to communicate, the opportunity, I should say, to communicate with clients. And so that's been a tremendous learning experience for me. Without that, I wouldn't be able to help very many clients. Let's change to bacterial culture. We all know that that bacteria has to be arrive alive. Culture swabs are usually with the transport media the best way to handle that. Appropriate specimens, there's no real need to cover that. It is very labor intensive. If you've ever spent much time in a bacteriology lab, they have to decide what are we going to look for. So we have to know the age, the sex sometimes, the species, the production type. So we can always streak it on blood auger, but do we need selective media? And then they have to look at what the growth is, the colony morphology, gram stains, run the sugars to help identify that organism. And then once they get it isolated and identified, then they have to say, okay, well, is this one that's significant in that species at that age? If it's a 3-month-old cat, E. coli is not significant, so we don't run the sensitivity on it. So the history that you provide, at least the information on individual animal, is very important. Of course, negative results are traumatic, and there are many reasons for that. But the strengths and advantages of bacterial culture is that we can simultaneously identify multiple pathogens. It's kind of a screen of sorts, I guess you could say. It allows sensitivity testing once we have that organism isolated. It does take pure colony reincubation. It allows for further typing and characterization, and of course you can also produce autogenous bacteriums. Multitoph, mass spectrometry, matrix-assisted laser desorption ionization. I'm not going to try to tell you exactly how this works because I really haven't looked into it, but it is a new technology, and it's very quick. It's very expensive. You still have to culture and have to have a colony in pure culture because it can identify mixed bacterial populations. And the reality of it is, for veterinary medicine, we're still building the database and validating it. So there's ongoing work for validation of the veterinary medical pathogens. It's simple. It's rapid. We're talking 5 minutes from the time you pull that colony off and prep it and run it through the machine. It's very accurate. We can probably we'll start identifying some of those organisms that are present rarely or in small numbers more readily and easier. And so that's we do not have one. There are several diagnostic labs across the country that have one. Our College Station lab is a much bigger lab. The MRL lab, they have one. They're working on it. Looks very promising right now. The thing we need to remember is a positive culture does not always constitute infection, and a negative, on the same hand, does not always eliminate infection. On the first bullet there, one of the most painful experiences I've had with my clients is storm deaths. And they go out and there's no pneumonia, but the insurance company wants to make sure or demonstrate that there's not, the pneumonia isn't why the animal died. So they collect all these normal-looking lungs and send them to us. And of course, we all know that Maltosta, Hemolytica, Histopathology, all those organisms are present in the upper respiratory tract. And so we culture these, and lo and behold, 30, 40, 50% of them have a bacterial pathogen, 1+. But we all know that that's not, we could and should expect them there. So you have to be careful in always interpreting positive results and negative results. Susceptibility, again, requires interpretation. Have to be careful. We've discussed for years, what does one sensitivity report on one animal for 1 yard mean? Probably not necessarily a whole lot. 2 or 3 of them that's where we have resistance to the antimicrobial that was used against those 3 animals that died, that has significance. So it can be in most instances, valuable for ongoing treatment. One of the most important things to me is, as long as we have the flow of those lungs through the lab, we're doing the cultures, we're doing the sensitivities, recording them, we have the data, we're helping establish resistance trends. Routine virus isolation. Again, we have to have a live virus on arrival. And not only that, probably really critical numbers. In theory, you can take one virus and isolate it. But that's usually not the way it happens. That can happen, but there are critical numbers, and the larger the numbers, when you reach critical mass, as you approach critical mass, that will assure you're more likely to get a virus isolated. You have to have a virus that can and will grow on cells. Relatively small numbers of antibody in the specimen or tissue. What we have determined, if we put an animal, if they're going to sacrifice an animal, and we get the tissues and they collect the blood, if you have if you have antibody to any of the 4 major 3 viruses that we routinely isolate, and it's even a low to moderate type, we rarely isolate a virus. So once a virus is present an antibody is present against a given virus, even if the virus is still there, we're not going to isolate it. The disadvantages: 5 to 7 days minimum. We do additional isolates. We will turn them out in 5 to 7 days, but we also pass them additional, even after we report them out, and we'll get another 2, 3, 4, 5% of the total number for the year. Positive results are not conclusive. We will isolate modified live viruses. We all know that. Negative results are not conclusive, very labor intensive. It is good to confirm the presence of a virus. This isolation allows further characterization. Is it a vaccine strain? And then we can do typing on it. We're moving to antigen capture ELISA now. Intact virus is present, but doesn't necessarily have to be alive. We can detect, again, vaccine viruses. The problem with the antigen capture ELISA, we really only have an antigen capture ELISA. BVD is primarily, as you know, used for PI testing. We've actually been using a human product for BRSV for a number of years. It seems to perform well. It's less sensitive than PCR. Antigen capture ELISA, it is a rapid test, relatively inexpensive. The detection of difficult to isolate viruses is a good tool, such as BRSV. It's more sensitive than some others and can detect both viable and non-viable viruses. That's ELISA technology. Let's go to BRD serology, virus neutralization, serum neutralization. Requires clean serum. Weaknesses, detection of an IG neutralizing antibody, not an IgM. A single animal titers results are difficult to interpret. A lack of uniform animal response, a lack of uniform antigen exposure. You can't confirm ongoing infection with one sample. And of course, vaccines will induce antibodies. The strengths and advantages of you can detect, this will detect neutralizing antibody, confirms the presence of antigen exposure. You can determine vaccinal response if you have a pre-vac titer. And if you look at the SOP, you wouldn't think so, but this is actually within a lab, is a highly reproducible test. I hope everyone in the back can see most of this, but I had a client call me up, and they were dealing with high-risk cattle. They knew they were buying them behind the market. They said, we want to determine why these animals are high risk. And so we sat down and came up with a plan. We're going to get at least 10 animals. We're going to collect serum, blood, and we're going to collect high nasal swabs. And now these animals are coming in. They're 4 weights, between 4 and 5 weights, and they've had wrecks with this origin before, so they want to know what can we do to look at this and maybe figure out what's going on. So, if you look, we have, if I remember right, we have 9 viruses in 6 animals. Wait a minute. Oh, no, I'm sorry, I'm on the wrong table chart. Start all over. These are just our virus isolations by month. And you can see, and the only thing, probably the most significant things, our percentage of recovery is rather respectable some months. You can see over here, 31, 16, 19, and so on and so forth. Some months our percentage of recovery is not very good. This is a total of 796 isolates, but you can see BVD, 82, IBR, 12, PI3, 2, other viruses. This would include coronavirus and adenovirus primarily. I failed to inform some of my clients that we do not culture BRD. It's a very difficult virus to culture. But recoveries are surprisingly good, and I think what's going on is people are not submitting and asking for virus isolation unless they're really pretty sure that they have a virus going on, a virus infection going on. Molecular diagnostics, the most important development in years. We can identify and amplify unique segments of DNA or RNA that are present only in the microbial agent targeted for detection. It's gel PCR was the first PCR we had. We'll skip over that. It's not as sensitive or specific. Turnaround times are not as good, but when you get into real-time PCR, appropriately collected specimens, we don't like them in gel, so we can use a swab that's been placed into bacterial transport gel, but we prefer to have them not in the gel. It can be expensive, or the weaknesses. Detection of vaccine viruses is quite obvious. It's very sensitive and very specific. Live pathogens are not required for detection. Relatively rapid turnaround time, in essence, about 4 hours. If you hit that specimen, gets there at the point in time and is checked in, when we're running that particular PCR, you can get a result the same day. Can't count on it. Again, we can now determine multiple microbial agents. It's called multiplexing, and so there are panels now that are available. Saves a little bit of money on expense on our end, and we give a real tremendous advantage on pricing. Semi-quantitative results, may not have time to go into that, but amplification cycles are really what we're talking about. Heating and cooling and heating and cooling, and that's multiplying those fragments of DNA or RNA that we're interested in. And if those come up above the threshold level early, then we know there's relatively large numbers of viruses there. If they go all the way to the upper end of what would be considered a positive, 35 to 40 CTs, then probably if it's there, it's there only in small amounts. And this is happening even now. That extract that we make from the sample that we proceed with testing, we can actually use that to do some typing. We can look for sequences that are highly conserved in BVD, and all strains of BVD will have it, and we can just tell you it's BVD, or we can look for sequences that are only present in type 1 or type 2 and tell you which virus you have. This is also important with high-consequence livestock pathogens because we don't have to amplify them to identify them. In fact, when you do the extract, you kill the viruses. So that's why there are a number of labs across the country that are now approved to run foot and mouth disease, classical swine fever, etc., because we don't run the risk of amplifying them and placing them back in the environment. Of course, BRSV is another one that is you just don't grow it. You have to use PCR and Antigen Capture ELISA. Okay, now then we're down to an interesting case. This is the lot that I was contacted, and they thought they'd had this problem for 2 or 3 years. It occurred about the time they changed the source of the vaccine. And they were continuing to have breaks, just one here and one there all across the yard, usually not more than one per pen. But they would treat them and they would respond favorably, so the plan was let's collect high nasal swabs on these acute pulls. And so we did. 18 nasal swabs. The bottom line was we isolated 2 IBR viruses, and they thought they had a CPE on a third one, but it didn't pass. And on PCR, we had 8 nasal swabs that were real-time PCR positive for IBR. And so no vaccination interference, so we know what was going on. We were having IBR breaks on this. We are using real-time PCR testing. We're finding 2 to 4 times the number of BVD viruses that we have routinely recovered by virus isolation, and so it brings up the question. I've already talked with 2 people at the meeting. I think one of them, I know, gave the talk yesterday, and I talked to another individual and asked them if they were using real-time PCR, and they said, nope, don't know how to interpret it. And so a new test is going to require some additional thinking and interpretation. We know that multiple viruses will come with multiple origin calves, shedding the virus on arrival, or they're incubating the virus on arrival. Infection can result before effective immunity in these scenarios. And we know that we don't always, just because they're vaccinated, we've looked at a number of groups of calves, 14 days plus, and that's the day the mark I've picked, and we will have little or no viruses in those. But in other calves, we seem to have numerous viruses on PCR 14 days after vaccination. And my thoughts were, if we are to assume the positive real-time PCR BRD panel results are likely the detection of vaccine viruses, then we discount the possibility of field strain virus infection in these calves 14 days post. In fact, if we assume they're going to be vaccine viruses, and then there's something wrong with that picture. We do know that these modified live viruses replicate once injected, and that's why we're injecting modified live viruses. We hope to stimulate immunity. That's why we vaccinate animals, to stimulate immunity. But these animals that are naive, maybe there's an overproduction of these modified live viruses, and that's why we still see them 14 days after the fact. We know our viruses can be isolated up to 21 days, the vaccine viruses, and so again, there's something wrong with that picture. What does that tell us? So calves without any previous exposure allows greater replication of modified live viruses. So that increases the chances of vaccine virus detection 14 days post-vaccination. Clinical infection. This is the case. My apologies, I'm there finally. Okay, this one's not on the screen altogether, but 1 through 10, this is the individual that called. We're having breaks since we changed vaccine manufacturers a couple years ago. It's not a big deal, but we'd like to put a stop to it. We'd like to know what's going on. Nope, I'm not there. I've already covered that case. My apologies. I'm trying to move too fast. This is the case where I was called up, and they know they're getting high-risk cattle. And so they say, we'd like to know why these cattle break. We know they're high risk. Why are they high risk? So 10 samples, nasal swabs, and blood samples. And if you look, 6 of these animals have viruses, and 3 of those 6, I believe, if I remember correctly, have 2 viruses. And so what can we learn from this? And I'm over my time, so I'm going to try to move as quickly as I can. But, whoops, that's quick. If you look at, well, let's just start at the bottom, right here. Well, my pointer is, there we go. If you look at this animal, we have 2 viruses. And if you look right there, the titer for BRS is less than 4. If you look at this positive over here, that titer is less than 4. So this animal, this is a recent exposure. This animal is probably shedding virus. He doesn't have any immunity to either of the viruses that he's carrying. If you also look right here, BVD, less than 4. Over here for IBR, less than 4. So this animal has not had previous exposure. He's naive, has not had a vaccine, and he's probably carrying and shedding 2 viruses into this pen of calves. You look at the next calf, and we're not going to have time to go over all these, unfortunately, but this calf probably had the infection upon leaving or before leaving the ranch of origin or at the older buyer's barn. But he's probably not had any vaccination either because you look, whoops, you look at the titers here, 4, obviously less than 4, less than 4, less than 4. No vaccination, but came from a herd or is picked up BRSV on the way to your lot. Look at the next animal. Now, this is the only animal probably that has had vaccination. No viruses, number 1. Number 2, a 32, a 16, a 32, and a 64. That animal, I would say, has had vaccination. You look at the next animal. We're positive over here. Now, this is the only animal here that has a titer. And I was mentioning earlier, with this titer, if we were to do virus isolation, we would not have recovered that virus because of that antibody, the presence of antibody. But if you look at the other 3 here, less than 4, less than 4, less than 4. This animal doesn't have titer, so this animal is probably again shedding virus. This animal has not been vaccinated. If you look, same thing here, positive. It does have a 4, but look here. Here's another one, positive, less than 4. We don't have there's no vaccine exposure. There was no exposure on the ranch of origin of a field strain. And so you get the drift looking at these. So this is what constitutes a wreck. Naive cattle. These cattle haven't had very much street exposure. They probably haven't had vaccine exposure. They may have been incubating a virus when they left the herd of origin, and they're going to be sick if they're not sick already. I forgot to tell you one bit of information. I asked them to select cattle, and they collected these as they went through to vaccinate them. Collect calves that look like they might be sick. They're going to be sick. They could be pulled tomorrow or the next day. So we do have somewhat of a biased population here. But naive cattle, no vaccinations, et cetera, increased probability of concurrent viral infection. You know, we vaccinate them hoping that we'll get an immune response before, in fact, the infection that's present in the pen creates a clinical infection. So probably I need to cut her off here. I had just some general things to cover, but I think looking at this last case, you can see what creates a wreck. Naive cattle that are already coming shedding viruses. There's a race between, we're going to vaccinate them, and these naive cattle, they have to have when we inject and try to create immunity, you have to have an immune system that's working normal, some degree of response. These cats probably don't have that. And so that vaccine virus would give it to them, and it creates certainly more than maybe even a subclinical infection. But it's in competition with the other viruses, and so the net effect is that they don't have any immunity. They become sick, stressed, and we create a wreck. Thank you.